Hello everybody, welcome at ESC TV. My name is Jurrien Berg. I'm an interventional cardiologist at the St. Antonius Hospital, Nieuwegein, the Netherlands. And I'm joined today by George Dangas from New York, who just presented the Paris trial looking at the cessation of dual antiplatelet therapy in patients undergoing stenting. You've done a large study now looking at this issue of discontinuation. What were the results?
Exactly. The Paris trial enrolled over 5,000 patients in 15 centers in 5 countries with a goal to follow them after a successful stent and see what happens over time regarding discontinuation, and even going more deeper into the subject in specifically and systematically categorizing the way the discontinuation may occur. The first category would be a recommended discontinuation by the doctor. A typical example of that we saw a lot in this study was at 12 months. A lot of patients got off the dual antiplatelet therapy. However, there are 2 other categories. One is the interruption, when a planned procedure is about to occur and a consortium of doctors speak to each other and recommend which agent is going to be held for how many days, and more importantly, when it's going to be restarted. And a third category, which by the definition of it is called a disruption, is a stoppage of a medication with no doctor involvement due to non-compliance or due to an acute event that the nature of it, perhaps bleeding, required an immediate stoppage of these related medications. It was interesting to describe, first of all, that the rate of the patients who remained on DAPT was the majority throughout the 2-year follow-up. And indeed, the different kinds of discontinuation categories occurred at 3% within 30 days, which is understandable, and up to 23% at 1 year, and jumped up to 57% at the 2-year time frame, out of which 41% was recommended discontinuation, I would say the more benign category. 11% was the disruption, 11% was the interruption, and 14% was a disruption category. So you see those, I would say, questionable or bothersome categories were really the minority. Obviously, this means that the majority of events numerically occurred in the patients on DAPT who were maintained on DAPT, obviously because there were so many. Yep. However, if we assess the risk of having an event following these 3 different categories, the disruption was the worst, and the interruption, the intermediate category, and the recommended discontinuation by the doctor was actually very safe, obviously because this was had already undergone a specific patient selection as well as a documented and well thought out process in order to achieve this recommendation. And the types of odds ratios we saw was between 2 and 3, which means a 3 times greater chance to have an event, and that spanned the events of composite of cardiac death, stent thrombosis, or MI, as well as spontaneous MI on its own. And interestingly, the MACE, when we included the revascularization procedure, had a somewhat lower odds ratio of 1.7 approximately due to the fact that it included a lot of planned procedures that had nothing to do with discontinuing the DAPT. In fact, if someone had a TLR, for example, obviously they would have to recommend it to stay on DAPT, so that sort of diluted the event. But the focus of our study, which was the death, MI, and the thrombosis, really fit nicely the hypothesis that the disruption is something that is not so good, and particularly in all categories, all types of events, they occur within few weeks of the disruption that occurs. Particularly, the odds ratio within a week can be as high as 15, which is remarkable. And if you consider the spontaneous MI, this risk continues even plus 31 days. So indeed, the time-related analysis of the study is very interesting on how actually the risk fades away once the initial insult, if you want, is overcome. I would not necessarily call it a rebound. I think that term has been suggested by some that once you stop a drug, this is a rebound. I think that some patients have a continuing substrate, and you just let it be, let it uncover when you withdraw some of the drug, without really being a rebound phenomenon the drug itself, the drug discontinuation or stoppage itself causes. And that's why I think the mode of how these drugs are stopped pans out to be quite important.
Yeah. So two small questions to you. Will it change our policy, especially the duration of debt after putting in a drug-eluting stent? I mean, in your data, it is suggested that discontinuation earlier might be even have a positive effect. So that's one question. The other question is, what do we tell our surgeons? They want to discontinue early, do antiplatelet therapy for another operation, for instance, non-cardiac surgery. And we were always reluctant to discontinue. Can we now say it's safe?
Well, our study did not directly address any of those, but I know that the referral basis and the doctors really want to know some of these answers, so I'll try to provide some insight into those. First of all, we saw that stopping both drugs at the same time was very deleterious. So I would say that's a message to the surgeons that stopping both drugs is not a good idea. And I think everyone's practice, for the most part, is to allow most operations to happen while on aspirin therapy, aspirin 81 milligram therapy. Yeah. And I think we would stay that way. And regarding also the other message of the study, that the interruption wasn't as bad as a disruption. So if someone wants to proceed with the surgery, that has to be done after a discussion with a cardiologist, the internist, and the surgeon in order to reach a consensus that this can be done. And in that case, the results can be safe, as opposed to just stop it at random and just proceed with surgery. So the message here would be that we cannot treat every patient the same way, and we have to stratify. And if indeed the judgment of a cardiologist and an internist is that a drug can be discontinued safely because the stent procedure was very simple, because maybe this was a single stent in the patient, or maybe because the patient is extremely low risk in general and had a simple stent procedure, that patient needs to be differentiated for another patient who had a bifurcation stent procedure in more than one location. Absolutely. And this and that and the other. So although both are stent patients, as in our study indicates that when the doctors get into the decision making, they find ways to select out patients that are compile low-risk characteristics, and in those patients, recommended discontinuation would actually be a fine thing to proceed.
ESC Congress 365 is your free access to ESC Congress content all year long.